fact that maternal outcomes are worsening in the U.S. is just unacceptable, and they're worsening for women of color a lot more than they are for Caucasians.
Hello, I'm Sheena Gill, and welcome to this episode of Early Detect Studios. Today, we are thrilled to feature Francois Debrant, Senior Vice President, Episodes of Care at Signify Health. Francois leads customer development for Signify's Episode of Care solutions. As an accomplished leader in the value-based payments and care world, Francois has spent close to 2 decades working to transform the U.S. healthcare system by improving incentives for providers and consumers in order to encourage value-based decisions. He holds a master's degree in economics and finance from the University of Paris and a master's degree in business administration from the Tuck School of Business Administration at Dartmouth College. Welcome, Francois.
Well, thank you, Sheena, and thank you for giving me an opportunity today to reflect on a lot of the exciting changes that are occurring in the U.S. Delivery system and in the payment world.
Absolutely. So why don't we begin with sharing with our audience a little bit about Signify Health. We would love to understand Signify's mission and vision and your role in making all of that happen.
Yeah, sure. So Signify Health is a relatively young company that stemmed from the combination of a few divisions. One focused on in-home evaluations, really working with Medicare beneficiaries across the country, and facilitated by a very large group of physicians, nurse practitioners who do these in-home evaluations, which include evaluations of diagnostic conditions of the patients, but also, and importantly, any issues around social determinants of health. And that brings us to the second part of Signify Health, which is and has been very focused on stitching together community-based organizations, exchanging information with a secure layered platform, and helping to both identify and, more importantly, to address social determinants of health and any number of plan members for Medicare Advantage plans, Medicaid managed care plans, and of course, under 65 commercially insured. And then the last piece of the Signify group is and has been focused on designing and implementing alternative payment models, and in particular, episode of care payment programs. And so when you stitch all of that together, what you get is a company that's highly focused on improving the delivery of care, trying to ensure that plan members, whether they be Medicare beneficiaries, Medicaid beneficiaries, or others, really end up by having happy, healthy days at home to the extent possible, and supporting the delivery system in its transformation by impacting the way in which the delivery system is paid. And my role is really to lead the organization in a couple of directions. One, continuing to support research, thought leadership, discussions with members of Congress as well as the administration to share lessons that we learn along the way in the implementation of our programs. And of course, engaging deeply with payers and employers in particular to help them understand what can be done and the results that can be achieved when you really transform the way in which the current delivery system works and how payment can affect it. So my intervention is across all these domains.
Wonderful, wonderful. So how would you describe the status of the value-based payments, the value-based care world today? What do you have to say about that? How far have we come?
Yeah, we've come a very long way. And the good news is that the transformation of payment in the United States is truly a bipartisan goal. So when you look at the evolution of value-based payments in the U.S., it hasn't really stopped, irrespective of who's in Congress or who controls the White House. both branches of the government, or all branches of the government, I think, are united in accelerating that transformation. And we've seen effectively each new administration building on what the prior administration has done, not destroying what the prior administration has done and trying to build something else, as can happen very often. So there's a lot of unity in this particular area, and for good reasons, because research continues to show that on average, Americans do not get the quality of care that is commensurate with the dollars that are being spent on that care. The U.S. Systematically lags other developed countries in both the quality of outcomes as well as the affordability of healthcare. So everyone understands that there's a lot to be done, and a lot has been done. One key indicator is a dashboard that's maintained by an organization called the Healthcare Payment Learning and Action Network, which was set up by the Affordable Care Act and really under the aegis of Medicare, CMS, and they track on a yearly basis the volume of dollars that are now being put into value-based arrangements, and they created a classification of value-based arrangements so that it shouldn't be good enough to say, oh yes, we have a large amount of our medical spend under value-based arrangements. What type of value-based arrangement is included in that mix? And so when we look at that dashboard, we see greater and greater portions of medical spend in what we can think of as advanced alternative payment models that include upside, downside risk for physicians, that really engage them in improving outcomes of patients. So a lot of progress has been made. I think it's uneven. Right now, both states in their Medicaid work and the federal government in Medicare lead the pack. And the private sector is close behind, but I'd say that it's close behind because of the actions of employers, who are really the ones that are pushing for an acceleration of how payment and new payment models can be adopted and implemented for their employed populations. So there's still a lot of work to be done, but everyone's moving in the same direction, and the pace certainly seems to be accelerating.
Wonderful. That's a great summary on where we are right now. So, Francois, you wrote an article in the New England Journal of Medicine that was very fascinating to me. And in that article, you said that risk is measurable while uncertainty isn't, and confusing them has a profound implication on the participation of providers in APMs. Now, as I said, this was just fascinating to us. Do you believe alternative payment models will scale when providers have more ability to measure risk? And moreover, what is the role of data and AI in all of this? And specifically, is the early detection of risk, both to save lives and dollars, integral to the value-based world? For example, a few things that come to my mind are, preventing avoidable C-sections or surgeries, or detecting preventable HIAs or false positives, and readmissions. Detecting mothers who can obtain care in their homes versus the hospitals. I'd love to hear about this.
Yeah, and let's focus in on maternity as a good example of where alternative payment models are absolutely essential. And where there's so much work to be done, because while I mentioned earlier that the U.S. lags other developed countries in outcomes and affordability, in maternal outcomes, the United States now is trending in an unfavorable way relative to other developed countries and countries in the pathway of being fully developed, and that's unexcusable. Given the total amount of dollars that are being spent on healthcare, the fact that maternal outcomes are worsening in the U.S. is just unacceptable, and they're worsening for women of color a lot more than they are for Caucasians, which is a double indictment quite frankly, of
Yes.
the state of healthcare. And so let's unpack a bit the notions of risk and uncertainty. So the challenge with a lot of physicians and obstetricians aren't any different in implementing alternative payment models is that when a payer, whether it's a health plan, a Medicaid agency, or an employer, approach an obstetric groups and asks them to participate in an alternative payment model, if they don't specify clearly and unambiguously the conditions of participation, what is going to be included and not included, how the program is going to work, whether or not there'll be shifts along the way, you're creating very high degrees of uncertainty. And as a result of which, up front, as I'm making a decision to participate and trying to determine what the likelihood is that I may end up downside, meaning upside down on that risk arrangement, I just don't know. So that uncertainty is going to become a phenomenal barrier in participating in that program. Another degree of uncertainty, which you mentioned, is that while I have an existing patient mix, that patient mix can shift during the performance period. And not understanding how that patient mix changes, not being able to assess appropriately the different ranges of risk factors associated to the women and the babies that are going to be included in the program, adds to that level of uncertainty. So risk is fine. Once you get rid of uncertainty, then as any going concern, I can assess the risks. I can figure out how to de-risk the program by doing certain interventions that have been proven to be effective. And at that point, it's up to me, right? It's not up to chance as to whether or not I could win or lose on the program, but it really is up to the team, how they approach the care of the women, what they do to improve the outcomes. And it becomes, at that point, the financial result gets very closely linked to the clinical activity of the provider, as opposed to the financial outcome being linked to a number of other variables that are outside of the control of the clinicians managing the patients. And so to your point around data, it is one of the absolute key essential ingredients in de-risking these programs and reducing uncertainty. So in other words, if up front, as a payer is approaching an OB group and asking them to participate in an advanced alternative payment program, if they don't reveal to them the historical past, what the case mix of the patients was, who the other participants in the total cost of the episodes were, and the differences in those costs, then I'm flying blind. Right? So I need data in order to be able to understand the past and be able to make better decisions about the future. And then when I'm in the program, I absolutely need to figure out what are the different risk profiles of the women that are included in the program, and what interventions can I bring to bear in order, again, to now de-risk the program itself. So I've taken uncertainty out, or I've reduced uncertainty a lot. It's now up to me, and being effective as a team in managing that pregnancy and the delivery is all about understanding the risks involved in that pregnancy and having clarity on that risk.
Absolutely. This conversation actually reminds me of some of your recent work. I want to congratulate your team for the great maternal health, the Signify Eastern Connecticut work that you have performed. This project was remarkably interesting as it involved data and analytics. It had a quality first goal. It had a longitudinal view. Please share with our audience a little bit about this project.
Yeah, and so this is part of a larger effort that was really prompted by the actions of the state employee plan in Connecticut under the leadership of the state's controller, Kevin Lembo, who with his team has been very active over a number of years in trying to get the delivery system to increase the value of the care that they're delivering for state employees. And so as part of that multi-year effort, the state hired Signify to manage a comprehensive episodic care payment program, contract with a number of providers in the state, and really then work collaboratively with those providers to improve maternal outcomes, in addition to a whole number of other conditions and procedures. And Eastern Connecticut is one of those systems that's very engaged in the state of Connecticut and has really developed a lot of internal processes, process improvements, quality improvement, engagement of teams, right? Because it's not just about the OB, but really when you're doing a global maternity episode that includes the newborn and postpartum care, you need the active participation of the facilities, the engagement of the pediatricians, potential engagements of other specialists who can manage any other number of conditions that the woman may have, including substance use disorders, mental health issues, and other medical conditions. So it really truly is a team approach, and kudos to Eastern Connecticut for bringing those elements together. And in their own admission, they likely would not have done it if there wasn't a different financial package, right, an episodic care payment program that gave them all of the reasons that they needed to push in this direction.
Very interesting. You know, another great project that comes to mind is your work with Texas and the Medicaid managed population. This project really stood out not only because of the ability to appropriately identify risks for mothers and for children, but also because of its focus on health equity and disparities. You know, social determinants of health is such an important part of the supply and demand healthcare equation. I would love to hear a little bit more about this project.
Yeah, great question. And the Medicaid managed care organization in Texas, much like Medicaid managed care organizations across the country and Medicaid agencies, are very, very focused appropriately on maternity. And in fact, we expect that this current administration will take some degree of action over the next 12 months to create either some uniformity in how states can approach alternative payment models around maternity, and or give some very specific mandates, I don't want to call them mandates, but instructions to Medicaid agencies across the country and goals around alternative payment models as part of the mechanisms to improve outcomes. And so this Medicaid managed care organization, very large in Texas, has taken the initiative to do this on their own, even without any federal or local guidance. And it's for understandable reasons. I mean, when they look at their population of Medicaid beneficiaries, it's a mix where you have many women who are at risk in their environment, at risk given other comorbid conditions. And you really need to change the way, again, in which you engage different parts of the delivery system and community-based organizations. Because in particular for the Medicaid population, engaging with community-based organizations has a very lasting positive effect. And not simply when the woman has a number of additional comorbid conditions such as substance use disorders or mental health conditions, but just generally speaking for the women and her after the baby is born, having support services, right, being able to link with community-based organizations that may help with just simple things like diapers, right, and formula for the baby. And we don't necessarily think about that, but there are a lot of those different types of supports that are really important for those women and their babies after the delivery, and that will ensure that both mother and child have better longer-term outcomes. Right. So all of this really ends up by being a multi-organizational collaboration, and ultimately the way these organizations are paid makes a big difference. In the fee-for-service world, everyone's doing their own thing. No one really cares about what the other is doing, and the patients fall into deep cracks. And so reforming payment is the way through which ultimately you reform the delivery system. But then you have to bring these pieces together. And it is exciting to see Medicaid managed care organizations like this one in Texas really stepping up and taking a leadership role.
Absolutely. So this brings me to the thought, many believe a fundamental flaw in fee-for-service healthcare is that diseases and risks, they're just identified too late. Some will say that the system is not routinely incentivized for early detection. On the contrary, though, value-based payments and value-based care, supported by data and algorithms for early detection it's kind of like a double whammy. Do you think value-based payments and value-based care, does it support early detection and thus improved outcomes? What are your thoughts on this?
Yeah, look, early detection ends up by being a very, very powerful lever of success. And again, in the fee-for-service world, as you indicated, it's not that the physicians or the clinicians don't care. It's simply that there's nothing in their daily work or their compensation system that gives them any type of excuse to do early detection of patient risks. And so when you're now, and this is the reason I mentioned earlier, the Healthcare Payment Learning and Action Network has a classification of alternative payment models from, minor, probably benign and not particularly effective alternative payment models to more population-based population management focused alternative payment models. And when you are responsible for managing a population of patients, so women who are having a baby is a good example of a population, if you're not actively looking at understanding and identifying the risks of the management of that condition, and in this instance also the delivery of the baby, then you have no idea what type of interventions to perform on behalf of that patient in order to improve the outcomes or the potential for positive outcomes. So that holds true for any other number of conditions or even procedures, because if you're a physician managing a whole slew of patients who have cardiac conditions and you're also going to do cardiac procedures, then understanding the risk profile of those patients, trying to optimize them before a procedure is going to reduce the potential for avoidable complications and poor outcomes on the back end. So there's no question that the early identification of patient risks, the early identification of patients that may accrue into a certain category or risk category in a managed population is an absolutely essential lever of success.
Absolutely. So, Francois, this is fascinating. In linking all of your answers together, it seems like a shift towards calculated risk will help scale alternative payment methods, which will enable early detection of disease, especially with data and AI, which will also, curb spending, and it'll improve options like moving health homeward and essentially improve health equity to, a positive degree, and which will overall shape behavior in the U.S. healthcare system in a more positive manner. Does that chain make sense to you? Have I captured it correctly?
Absolutely does. And look, there's an old saying that form follows function. And in our world, we also think that function follows incentives. So if you reshape the incentives of the delivery system, then you change the fundamental functions of the delivery system, and the shape of the delivery system will then evolve. So what the delivery system does, the function of the delivery system moves from individual encounters and managing individual encounters to manage patients over time. And you simply can't do that effectively without a whole number of different processes that support those functions. So it is a complicated long-term evolution of the system. We see, however, the speed with which the delivery system adapts when the incentives change because they understand clinicians are incredibly smart. And so they know what needs to be done to improve outcomes of the patients. They often, again, struggle to find the funds to get that done. But when you change incentives, you change effectively the pool of funds that are available for physicians to transform the way they deliver care. And all of that ends up by having very positive impacts on outcomes.
Absolutely. So I know most would agree that some shape of payment reform is needed to curb spending and shape behavior in the U.S. healthcare system. But some will also say that payment reform alone will not solve the complex problems of, like, for example, preterm birth or maternal mortality, and that there are clearly things like clinical advancements that are necessary. So certainly, the value-based world is a part of the equation. But from your perspective, what else is needed to really advance healthcare in the United States? What completes that chain we just talked about?
And I'd say a few things. So one, it's being honest with current outcomes and not taking them for granted that they can't be changed. And they can be changed. And so, and I think maternity is the conversations we have with obstetricians are always enlightening, because you very rapidly get into the different component pieces of the pregnancy, the delivery, the newborn, and the postpartum care. And obstetricians will say that it's really difficult to change the current ratio of C-sections to vaginal births, which in the U.S. is one of the highest in the entire world. And that's simply not true. And we know it's not true because in Utah, the C-section rate is actually roughly at the level recommended by the World Health Organization at below 20%. And so it can be done. The question is, why isn't it being done in Utah and it's not being done everywhere else in the country? Well, some of that is cultural, but some of that is also how the obstetricians, working with the pediatricians, working with the families, working with community-based organizations, really change the narrative around what's good for the woman and the baby. And to give you a counterexample to that, I was on a call the other day with someone from a Medicaid agency who had just done a number of focus groups with women who had had babies in the past year, and who were expressing how they felt going through that event. And a number of them said that the physician didn't even ask them whether or not they wanted a C-section. They just performed the C-section. And so we see this disparity in the way in which women end up by experiencing the pregnancy and the delivery. And there is no excuse for those disparities, and as a result of which, it is absolutely essential, as I said, to be honest about what we have today, and to then set very clear goals on improving those outcomes, and they can be improved, right? So it's honesty and recognition that the current state of affairs is poor, and can be approved, but again, it requires a whole number of then underlying process changes and structural changes. But I think that core objective view of it really isn't good, and let's work together to make it better and set very clear goals for improvement is one of the absolutely essential steps.
Indeed. Thank you so much, Francois, for this very interesting and thought-provoking conversations. Would you like to share any closing remarks?
Only that, as I said earlier, we're making great progress, and it really takes, I think, the engagement of policymakers, of members of the administration, of researchers, of organizations, like yours and ours, to make change happen and to bring all these pieces together in order to improve outcomes for patients overall, and then certainly favorably impact affordability of healthcare in the United States. And I'm going to continue to remind everyone that they have a role to play, and in particular, those who pay for healthcare have the biggest role in demanding more from the delivery system, demanding better outcomes, and then demanding from those who administer those dollars to do something about it, and not continue to stay in fee-for-service, but continue that acceleration towards value-based payments.
Wonderful. We are so delighted to have had you on our show, Francois. Your contributions to improving and encouraging value-based decisions in the United States are very noteworthy, and we wish you and Signify all the very best and continued success in your mission. To our audience, we hope you've enjoyed this exciting episode of Early Detect Studios. Until next time, be well.